My name is Judy McIntyre, and I would like to share and review some dental trauma essentials. We've all seen dental trauma in our office, and it can present in numerous ways, from minor infractions or chipped teeth to pulpal involvement, mandibular fractures, alveolar fractures, root fractures, and luxation injuries or the complete loss of the tooth. The important thing to do is to stay calm in all of these injuries and their management. It's also important to have great documentation on all of the cases. So today I'd like to review with you my tips about documentation. So usually dental trauma presents with three different types of dentition. So you have primary teeth, you have secondary teeth, adult teeth, and then you also have the mixed dentition, which that age group, unfortunately, is the most susceptible to dental trauma when they're in the middle of their development. So you have some primary teeth and some adult teeth. You also should always take a hunch and try to document the trauma diagnosis. As well, you're also going to want to do, when possible, pulp vitality testing that day, and you're giving every tooth an endodontic diagnosis, so a pulpal and periodontal diagnosis. It's important also to take photos of these cases as well as proper imaging. So proper imaging either includes x-rays or CBCT if you have access to it. What you're also going to want to do is make sure that the patient is comfortable. So after testing, if they would benefit from anesthesia, you can anesthetize these patients to get them a little bit of relief of pain. And then if you can that day, you can treat, but most oftentimes that is postponed until a little bit of healing and a little bit more comfort arrives. Then you should consider referring, if any of that is needed, either to the oral surgeon, the endodontist, or a pediatric dentist if you're a general dentist. And document all of this. It's also important to discuss at this visit the follow-up schedule for these patients so that proper expectations are laid out from the beginning. So today, I'd like to discuss the injuries primarily in the mixed dentition as well as the permanent dentition. There are 5 types of injuries that affect the teeth. You have infractions, craze lines. You have uncomplicated crown fracture, complicated crown fracture, crown root fractures, and then the root fractures. These all affect the teeth, the dentition. You also have periodontal injuries, and the periodontal injuries are 7 kinds. So you have a concussion, which is a light bump. You have a subluxation, which is more of a bump, but you're going to see crevicular or sulcular bleeding in a subluxation. You have intrusion, extrusion, lateral luxation, which essentially all of those mean that the tooth has moved up, down, or sideways, or buccal palatally in any which direction, and avulsions, and then the more severe alveolar fractures. Outside of the dental office, the best treatment in an avulsed tooth scenario is to wash the tooth gently and replant it if possible. It's not only important for you to know this information, but it's also super important to empower your front desk and reception areas so that when they get these hysterical calls, they can properly advise the patient or the parents on the other end of the phone. And time is of the essence in these injuries. So it's really important to know this. If they're not comfortable or unwilling, or they just can't replant it, the best storage medium for these teeth is milk. Milk is usually more readily available than the other storage media, although I do want to address storage media. The best overall storage media is the Save-A-Tooth kit that can be ordered on Amazon or most medical supply houses. So a lot of school nurses will have the Save-A-Tooth kit, but you can get it on Amazon. essentially in the Save a Tooth kit, it's Hank's Balanced Salt Solution, which is a organ media solution. It's used for, salvaging and transporting organs in the hospital setting. So it's the best solution. And then that is better than milk, although milk is a very good solution. And those two are significantly better than all of the other options. If milk is not available, saline, sterile saline, and the patient's vestibule. You can ask the patient to store the tooth in their cheek and try not to manipulate, chew it like bubble gum. If that is too risky to ask the patient to store it in their cheek, what you can do is ask them to spit in a Ziploc bag and put the tooth in that bag of spit and then transport it that way. What you want to convey over the phone, what you want your staff to know over the phone to educate the family on the other end, the patient on the other end, is not to put it in water and not to keep it dry. Don't put it in a Kleenex. The dry and water environments are both very detrimental to the PDL cells of the tooth. So milk has the most ideal osmolality and pH and will preserve PDL cells for up to 8 hours. And if you have your choice, skim and cold milk is best. Shelf-stable Parmalat, which can be bought and stored readily, like in a pantry or in your car, similar to Hank's Balanced Salt Solution or the Save a Tooth kit. Parmalat is also a great option, similar to milk. Again, the worst is tap water or dry and not in a Kleenex. So when the patients finally get to you, it is important to ask where the tooth is in these avulsed cases so that while the patient is filling out paperwork, the tooth can be rehydrated and stored properly in either milk or, if your office has it, the Save a Tooth kit. Once they're in your office, obviously, especially in the avulsed tooth scenarios, you want to check that, you want to look clinically at the tooth and then take proper imaging. When there's a missing tooth, you want to check the socket visually, and you're going to want to suction the blood clot out. And then you're also going to want to count and ensure that socket is empty with proper imaging. So you can either take a PA or, as I said before, a CBCT if you have access to it. You want to look at the tooth before you replant it. You want to make sure that it doesn't have a pebble on it, gravel, dust, any kind of debris. But you don't want to scrape that debris off. You want to gently rinse the tooth under even tap water, but very quickly. We're talking about seconds here. You also want to review their medical history. If they've already been cleared by the hospital or the emergency department, that's one thing. But you want to confirm their status, tetanus status, and maybe refer them for a booster if needed. Again, you're doing imaging and pulp testing at this time, and you're documenting the type of trauma, the endodontic diagnosis, which involves pulp and periodontal diagnosis, the apex maturity, right? Is it closed or is it open? And how open in terms of millimeters radiographically is it? And the details of the trauma. Believe it or not, patients, families forget the details very quickly. So how long was it dry on the floor? From that dry time, how long until it got in a storage medium? What was the storage medium? How long was it in the storage medium until it got to either your office or replanted? All of those time amounts are important to document because people will forget them. And then also documenting the nature of the injury. So, this is a usual type of dental trauma. You can see it's pretty gory. We have a luxation. We have injury. Sometimes there's fractures involved with the crown. And these are the images that were taken of the patient that day. You can see, maybe you can appreciate that some teeth have moved, but really on these attempted periapicals or occlusal films, there's not much definitive information to be had here. What I might think I see are open apiced lower anteriors that may have moved, and possibly luxation on the maxillary anteriors, but I'm really not sure. So we're also, in terms of imaging, we're also going to ask the patient, and if parents have old pictures, hey, is this what your teeth looked like before? Is this how your smile was before? Is this how you feel that these teeth, where they were before the injury? And really, most often they can tell you, and usually moms do have pictures close up of their patient's smile. So this is very informative. And I usually ask the patient or the parent to email my office those pictures, and then we keep that in the chart so that we can do comparisons. So while those occlusal films were decent imaging, the IADT recommends for all dental traumatic injuries angled films. So what you're going to do is you're going to take a straight on PA of the teeth that were injured, as well as the adjacent teeth, and then you're also going to take angled films. So if this is straight on of 7 and 8, you're going to go 30 degrees up, and then you're going to go 30 degrees down with the x-ray head. And that's going to rule out, hopefully, root fractures on your teeth, on these teeth. And don't forget, in these scenarios, that it's not just the tooth that is most obviously injured or moved or avulsed, but opposing teeth usually also get a little bit of bystander injury as well. So it's important to x-ray those teeth as well. So from this case, here's a case where I did take the angled films from a while back, and we can see that we can kind of suspect that there's some fractures in the tooth. But I love sharing this case because I would have never suspected that this case had so many shards within the tooth, right? What we see on the x-rays was nowhere near what I suspected and found out and resulted in clinically when I started picking out all of these fragments of teeth. And I really wish I had known what better to expect so I could have been better prepared, right? As a practitioner, I love to be prepared and know what I'm getting into. So I love that the AE and the AOMR have, in their joint position statement, recommended that CBCT is the imaging modality of choice for traumatic dental injuries. In the US, the access to CBCT is much more prevalent, and I can say that dealing with many and many of these injuries and luxations, CBCT is able to inform us so much more significantly of what actually is damaged or moved or the injury that has occurred versus traditional PAs and angled films. For example, this case. So this case, you can clearly see that there's root fragments that totally would have showed up on a PA, right? The root fragments, very clear. We all agree those would have shown up on 2D imaging, as well as these crown fractures on the mandible also would have shown up on the 2D imaging. But with the CBCT, we were also able to appreciate that there's a crown root fracture on those lower mandibular incisors, and not just a crown root fracture. This is the most ideal crown root fracture, right? It's right at the bone level, and I can easily remove this fragment, possibly either extrude surgically or orthodontically, and this tooth now has a great prognosis, whereas not knowing the extent of the crown root fracture, had it been any more apical in fracture direction, we might having a different conversation, and that patient might end up losing that tooth, right? If it was more mid-root. So I love 3D imaging because it's super informative and gives me a lot more value. So you can see here on this different 3D image that this is a maxillary tooth. the crown root oblique fracture is actually extending into the bone, that's going to be a more surgical removal of that fragment or the loss of the tooth, depending on a lot of other factors. This is another case that I love to show the value of 3D imaging because, number one, we can actually quantify how open the apex is. And that is super valuable because, according to dental trauma guidelines, the more open an apex is, the more likely it is to regenerate or revascularize. And that's valuable information because in these cases, we're going to be a little bit more conservative and allow the body the chance to heal. To review, pulp vitality testing is super important also because we need to test with endo ice and percussion, and usually palpation. Those are the 3 baseline exams of pulp vitality testing that I like to do in trauma cases. Remember, please, that ice cubes are not cold enough, so please use a refrigerant spray like endo ice when you are pulp testing. What I also do on kids is I do a lot of fake tests to make sure they're being accurate historians. With children also, I like to test their fingernail first so that they get a sense of the cold sensation and they're not too alarmed by it. These following slides I would just like to show you so that you know what to do. And again, they're all online under the IADT dental trauma guidelines, but feel free to screenshot them. They go over dental injuries and their management for permanent teeth, as well as the follow-up schedule for permanent teeth and how long you're going to splint, keep a splint on for these cases. And for periodontal injuries, also in adult teeth, how long to monitor, how long to keep the splint on. And please remember, in avulsion cases, you're always, always, always on an adult closed apex tooth doing a root canal within 7 to 10 days of the injury. So do not pass go, do not collect $200. Every single time an adult tooth is knocked out, you are always doing a root canal or sending them to the endodontist within the week of the injury, okay? For luxation injuries, it all depends. The farther the tooth moves, right, usually anything greater than 3 millimeters has a lower prognosis, a more guarded prognosis. And then again, 7 millimeters or more usually has a very poor prognosis. And usually in luxation injuries with 7 millimeters or more, usually a root canal is going to be indicated in those cases as well. So I hope you can screenshot those slides and feel free to refer to them. For immature teeth, we have a little bit more of a watch and see approach. And remember, in primary teeth that are avulsed, never, ever, ever replant those primary teeth because of the secondary adult tooth bud behind it that's still in development. The follow-up schedule also for periodontal injuries is here. And remember, you're splinting anything that's mobile for up to 4 weeks, a little bit longer with alveolar fractures. And usually the oral surgeon should be involved when there's an alveolar fracture. So to review, avulsion injuries and the success of their outcome is dependent on 3 major factors. So is the tooth permanent, or is it an immature permanent with an open apex? How long was the tooth out of the mouth? So total dry time, and what was the storage medium? And then for luxations, again, the extent of the tooth movement. Again, document all of these 3 factors: storage media, length of time the tooth was out of the mouth, and the development of the tooth. And for the luxations, how far did that tooth move, or how far does the patient think the tooth moved, because they're going to forget. For antibiotics in an avulsion scenario, you are, when the patient is younger than 12, the risk of staining with tetracyclines, because tetracyclines are the antibiotic of choice in adult teeth, the risk of staining is high. So for patients ages 12 and younger, you're going to be using penicillin. Feel free to screenshot that this slide as well. And then for adult patients or patients older than 12, you're doing doxycycline. For more information, feel free to check out these 4 websites. As well, any of my articles, if you Google my last name, Judy McIntyre, dental trauma, you should come up with some good resources as well. And there is a webinar on dental trauma that Dexis and Viva Learning provided, and you can find that on the web as well. So thank you for all of these cool cases and others. You can also check out my Instagram page at Dr. Judy Endo. Thank you so much, and feel free to email me with any other questions that you might have. Thank you.